Hello, and welcome back to our clinical case series. So hopefully you've learned some tips and tricks along the way for the last three cases that we've discussed. Today's case is going to be a little bit more complex. We're going to focus in on lateral window grafting techniques. So sit back, relax, and let's dive into some key learning objectives to take home from today's clinical presentation. So three main learning points to understand to help you, one, realize when this procedure needs to happen, and two, understand kind of complexities and the intricacies of the procedure itself. So, first off, I want you to describe the indications, contraindications, and relevant maxillary sinus anatomy for a lateral window sinus approach. Second, I want you to be able to differentiate between when are we going to do a lateral window technique versus an indirect technique. And a little sneak peek, it depends on residual bone height. Finally, I just want you to be able to recognize a few of the common complications that can happen with this procedure. So if the patient calls you, you can tell them that this is very normal. So, three key learning objectives to take away from today's lecture. It's a little bit more of an interesting case. This fixed hybrid was placed with 7 implants about 8 months ago. 7 implants were placed. 2 implants were placed in the most distal tuberosity areas on the upper left and the upper right. When it came to the time of stage 2 uncovery, restoration was removed, and the implant at site number 15 failed. There was sinus proximity in the 3-4 tooth location area and also at the 13-14 tooth location area. So those vital structures were avoided at the time of implant placement to reduce any sort of bone grafting that was needed. So the all-on-X procedure was a graftless solution approach. As an interesting side note, this is a 3D printed hybrid restoration that is done with the Sprint Ray printing technologies. More on that to come later, but just understand that's my preferred treatment modality when it comes to delivering interim fixed hybrid prosthetics. You can see here a very nice result that happened from the 3D printing here. So let's dive into our CBCT imaging. Just a bunch of different cross-sectional views. You can see here highlighting the maxillary sinus. Let me click here. Let's get a colored pen. But you can see a large cavernous sinus both in the right and left maxillary sinus. So that's why these structures were avoided, to avoid lateral window placement at the time of the all-on-X hybrid. However, with that one implant failing in the maxillary left posterior section, we need to figure out a different solution to treat the area for the patient. So, when it comes to my decision making, what we're going to look at is what's the residual bone height. If it's 5 millimeters or more, so usually 5, 6, 7 millimeters, my preferred methodology is going to be an indirect sinus technique. When there's 5 millimeters or less, we're going to do a lateral window approach. Now, furthermore, with doing the lateral window approach, implants can be placed simultaneously. It really depends on the bone quality, bone density, right? In terms of, and also to how much residual bone height is present. If it's 3 to 4 millimeters, typically you can go ahead and proceed with implant placement and lateral window grafting. However, for this case, we're going to do a staged approach, meaning that I'm going to do the lateral window grafting first and allow that to heal prior to moving forward with an implant in that left posterior section. The other thing too to keep in mind is there's a large voluminous space. So I'm going to need a large amount of bone grafting when it comes to completing this case. Let's just look at another different view here. So we need to kind of recognize and understand that the mesial marginal ridge is kind of going to be the most anterior part of the anterior maxillary sinus. So from there we can kind of understand and we can decide in terms of where are we going to make our flap design, where's our vertical incisions going to be, because remember we need good access to see when it comes to the lateral window grafting approach. So here's the fixed hybrid in place. So remember how we talked about that interproximal area? So that's just a good rule of thumb in terms of where that anterior wall of the maxillary sinus is in that maxillary left posterior sextant. So we want to split as much of this keratinized tissue as we can. So we're going to go crestal, and we're going to split the KT on the facial aspect, so I don't have to remove the prosthetic, and then drop the vertical here. And then I'm also going to drop a distal vertical at that location as well. This will allow for easy closure, and I've given myself enough tissue to suture to. And the reason why we're able to keep that prosthetic in is because of the wide band of keratinized tissue. This all goes into my incision design and my lateral window access. So again, just a different view, seeing what that tissue looks like from a different angle. And again, just one more view here. So as you can see, my incision design, just like we had talked about, a distal vertical, kind of more of a mid-crestal, kind of cheating to the buckle a little bit, wrapping around and dropping our vertical off of the mesial aspect here. So we know, based off of our CBCT, roughly where that window should start. It's going to be kind of right in this area. We can go back as far distally as we want. The one vital structure we need to look for and be mindful of is the anastomosis between the PSA and the MSA. It's going to be that vital vascular structure we want to avoid. In this case, it was not visualized on the CBCT, so we really don't have much to worry about. Here again is just a different view. Sometimes these photos can be a little bit more difficult to take, but just want to give you an idea of what that maxillary sinus looks like and giving you some different views prior to opening the window. So this is a really nice full thickness flap, clean flap reflection, making my incision down to bone using my Oraband knife to score the periosteum prior to reflecting that tissue with the number 9 periosteal elevator. But you can see here, good flap access, and my proposed window really should kind of start in this area here. It should be about 2 millimeters from the crest of bone and making a large oval access kind of in this area. The common tendency when it comes to a lateral window technique is you're going to want to make your window too small. If you make your window small, it becomes more difficult to lift the Schneiderian membrane off because of access, right? When you open up the window, you want to be able to put that instrument on bone, but separating the Schneiderian membrane from the bone itself. A good analogy for this is think about removing an egg shell off of an egg, but not penetrating into the yolk. That you notice how there's that thin gray membrane of an egg. That's very similar to this technique. So you can see here, good window access. I should have been a little bit more apical in this portion here. And I actually should have been a little bit more mesial. It would have made my sinus access easier. In terms of access techniques, there's two different choices in terms of instrumentation to use. I prefer rotary instrumentation. I tend to use number 8 or number 10 diamond burr, and I go until I see the gray hue of the Schneiderian membrane. Some people may elect for a piezosurgery unit. What I find in my hands is the piezosurgery unit takes too long. The other thing too is some people may do an outline and keep this buccal bone, and they may use that as the new floor of the sinus. I prefer to remove the bone completely and reestablish the sinus floor with grafted material. Just my preferred technique, but just know there are multiple techniques when it comes to surgical access. So you can see here the intact sinus membrane, some minor bleeding. And what you'll do is you'll go in and you'll remove any of these sharp ledges with, again, the rotary instrumentation as you're placing your bone graft material. Again, just another view looking into the sinus. You'll see a surgical video here in just a second using a sinus curette, different from your other surgical curettes. They're more blunted, so they're softer around the edges of the instrument to help not perforate the sinus floor. The other thing that's really important is we need to get good blood supply for this grafting. So we need to get that instrument all the way to the medial wall for good blood supply. So let's watch this video here in real time. So you can see here maintaining the instrument on bone and just kind of showing the depth of the maxillary sinus. You can see the patient breathing and you can see that Schneiderian membrane moving up and down. So that's how you know that you've done a good sinus lift and that the Schneiderian membrane is intact. You need to be mindful of if you're going to perforate the sinus floor, it's going to happen when you first start lifting the Schneiderian membrane. And the most difficult part in terms of lifting the membrane is going to be surgical access along the apical border of the window. So when perforations happen, this is the most common area right here. Let's watch that video one more time here. So you can see maintaining that instrument again on bone, really important to do. When it comes to large grafting cases, I tend to use a bone graft that resorbs more slowly. So in this case, I used a mineralized cortical graft, small particle. I tend to hydrate my graft in whole blood, and then I use an NDA laser on the hemostasis setting, a long pulse duration, 550 microseconds or 650 microseconds, to get good hemostasis. This bone will be much like sticky bone using PRF. I like to hydrate my bone in whole blood. So this just shows a photo of the graft hydrated in the whole blood. Just another different view here. And now you can see the window is packed. A couple things to take note of here that there are no photos to show. First, what I will do is I will place in a resorbable collagen membrane at the floor of the sinus prior to placing my graft material. Why? It just helps protect the graft. The bone grafting is sharp. You can perforate through the Schneiderian membrane, and then you can have residual particles floating in the maxillary sinus. We really don't want that. So it's just an added measure of safety for the patient. The other thing that I do when I'm placing my graft is I actually load the graft up into a syringe. And I get the syringe as far into the sinus as I can, and then I push the syringe and the bone grafting comes out. And as the bone comes out, I will change my instrumentation to a number 9 periosteal, and I'll turn it onto its side, and I'll push the bone distally, and then I'll push the bone mesially, right? So I'm packing laterally first every time I'm putting that graft material in to avoid any voids in the maxillary sinus. So by doing this technique, by using the periosteal and using it in some sweeping motions back and forth into the sinus, you'll get good condensation of that bone graft. Again, just another view here. So once we're about ready to close, the next thing I like to do is I want to put another resorbable collagen membrane over the window access. So again, here both membranes used in this case are resorbable collagen membranes. They are the Creos product from Noble Biocare. So here we are having our resorbable membrane draped over our lateral window access prior to closure. And then you can see here good closure using a combination of resorbable and non-resorbable sutures. In this case, I wanted to make sure that that flap was going to stay closed. So mostly we used the resorbable sutures along the verticals and then our non-resorbable more on the crestal areas with good areas to access to remove relatively easily. So let's look at our graft here on a CBCT image, and let's see how well we did. So good volume height, right? You can see here, I made it all the way to the anterior wall of the maxillary sinus, and then I made it also to the distal wall of the maxillary sinus. From the floor of the sinus to the crest of bone, about 20 millimeters in height. You can see roughly, if you use that 20 millimeters, about 4 millimeters of residual bone height in that cross-sectional view. Let's look at it from an anterior posterior view. So about 16 millimeters of width. And you can see here we've made it all the way to the medial wall. So we're going to have good blood supply. As a general rule of thumb, in terms of wound healing, for every millimeter of bone height, we want to allow 1 month of healing, just as a general rule of thumb. Am I going to wait 16 months on this case? No. But this case, I am going to let sit for 9 to 12 months before re-entry because that's asking the body to do a lot in terms of regeneration and healing into the maxillary sinus. And as you can see here, a lot of width, 30 millimeters of width gain. So I placed about 8 cc's of bone graft at the time of the lateral window sinus technique. All sinuses are different. The one thing to kind of be mindful of when you're doing these lateral window sinus grafts is, are there septum or not? This sinus floor was relatively flat. The more flat the sinus floor, the easier the lateral window sinus technique. The other thing to be mindful of too is, what's the residual bone thickness for access into the window? The thinner the bone, the actually easier it is to access. When you get areas that are very thick, it can be a little bit more challenging, right? And in terms of when you have thick buccal bone, sometimes you're going to switch over to a carbide burr first and then access with a diamond burr, right? So all different things to be mindful of when you're going in and you're doing this lateral window approach through a lateral window surgical technique. So now we let things heal. We let things heal, and then we're going to go ahead and we're going to place 1 or 2 more implants into that distal most aspect in the 14-15 area. What I will do for this case in the interim is I will keep the patient in that printed hybrid restoration. And what I will do is I will fabricate a surgical guide and I will use the fixed hybrid as dentition for the surgical guide itself. So we'll be able to keep everything in place and place 1 or 2 implants. This is just a proposed implant that I did in DTX Studio at the time of my follow-up CBCT. So I like to take a scan, if I can, day of the procedure, if not, at the 2-week follow-up. So as you can see here, everything went quite well. A couple of things in terms of difficult cases and difficult management here is perforation of the sinus floor. That is a complication. It can be managed in a lot of different ways, but for this lecture, what you want to know is sinus perforations do happen, and they happen quite frequently, but there are ways to repair them and continue to move forward with a sinus graft. You can see here a large volume of bone. I think those are 15 millimeter implants, just as a reference point. The other thing to be mindful of, like we had talked about, is sinus floor anatomy. Are there septum or are there not? We know there's a high percentage of septum present in the maxillary sinus. That makes these cases a lot more challenging, and sometimes you have to do maybe 2 windows, right? Or one very big lateral window. Because when you're dealing with septum, right, a peak of bone in the sinus, you have to come in from different angles and remove that septum and remove the Schneiderian membrane off the septum itself. So just some things to be mindful of when it comes to lateral window sinus grafting techniques. So again, I want to review some of the key learning objectives. So just we wanted to describe the indications, right? Contraindications in sinus anatomy. So Indications for a lateral window sinus graft are going to be 5 millimeters of bone or less. Contraindications, if there's sinus pathology, if there's cloudiness in the sinus, you're going to want to refer to the ENT first prior to moving forward with the sinus grafting procedure. Again, we want to make it to the medial wall of the sinus for good vascularity and good blood supply. Appropriate surgical techniques, instrumentation. So we talked about that. There's special sinus curettes that we use for lateral window techniques. And remember, you need to have good surgical access. Typically, again, I'm using rotary instrumentation with a diamond burr. If the bone is really thick, I will use a carbide at first and then move into a diamond burr. Remember too, I also like to remove all of the bone. Some people will keep part of the buccal bone, push it inward, and make that the new reestablished sinus floor. Another instrument you can use is a piezo surgery unit. It just takes more time. So, some of the common postoperative complications are going to be sinus perforations. And the other thing to be mindful of when you're completing these cases is sometimes you can get some post-nasal bleeding on the side where you did your sinus lift. Very common. So, I tell my patients that before they leave the operatory. And for cases like this, I more often than not tend to do them with moderate conscious sedation. It makes the patient a little bit more comfortable and it actually will make the procedure go more quickly in my hands. So again, thank you for joining in for today's lecture. Hopefully you enjoyed just a quick review of a lateral window graft technique. Again, you may not be doing these techniques and you may be referring, or you might be starting to do these techniques. If you want to learn more in the step-by-step approach and watch a full surgical video, you can check out my other module, the surgical techniques module. And that is it for today's lecture. So again, the quiz, three quick questions to make sure that you understand the learning objectives. And we will see you next time for clinical case number 5. Thank you so much and have a great day.